Welcome to Medical Monday on E-Radio with myself, Jon, and ophthalmologist Dr. Dylan Joseph. Dr. Joseph, are you well? How's it going?
Good morning, Jon. Yes, very well, thanks. Winter's come up too quickly, but that's the garden route for you, isn't it?
Yeah, I know. It's all frozen here on my side. I don't know about you.
It is.
yeah, everything's frozen.
Yeah.
That's it. But listen, today we are recapping keratoconus, and I'm so proud of myself because I can finally say the word. I remember in our previous discussion a year or so ago, I couldn't say that word. I asked you to say it.
Yeah, keratoconus. You did it perfectly today. There's no problem with the pronunciation.
Yes, and I can say ophthalmologist as well. I've come a long way.
There we go.
So let's quickly recap on keratoconus. What exactly is it?
Yes. So keratoconus is a genetic abnormality of the front part of the eye called the cornea. And the cornea is usually shaped like a sphere or a soccer ball, rugby ball shape. Incorporated into it. So we actually call it spherocylindrical, sphere and cylinder, so soccer ball and rugby ball. But when this shape becomes an abnormal rugby ball shape, so if you can imagine old Blue Bulls Mornay Steyn getting hold of a rugby ball and kicking it around a pitch for a while and distorting it, that's what keratoconus is. It's an abnormally distorted front part of the eye, or the cornea. Now, the cornea needs to be a certain shape so that when the light rays travel through it, all of those light rays, whether they're going through the center of the cornea or the periphery or the outside of the cornea, they fall at one spot on the back of the eye. But in keratoconus, it creates almost a multifocal cornea because those light rays are not traveling through and meeting up at one point at the back of the eye. They're meeting at multiple points at the back of the eye. So it causes significantly reduced quality of image, ghosting, haloing, starbursts. People complain about quality of vision, and you cannot correct it then well with a contact lens or a spectacle. Now, remember I said this is a genetic entity, so it's inherited from either mom or dad, but it only expresses itself usually in young teenagers or people in their early 20s by rubbing the eyes or abnormal sleeping patterns. So if you sleep on a pillow face down on your left eye or your right eye, and you've got the genetic coding, and you do that for a third of your life, which is what we sleep, then you are going to change the shape or break down the bonds within the cornea. You do the same with rubbing. So people with allergic or atopic disease, asthma, hay fever, sinusitis, eye rubbers as children, as teenagers, if they've got the genetic propensity for these bonds to be broken down, they just need the stimulus. And that stimulus is in the form of eye rubbing. So it's either knuckle or a finger or the palm of your hand. So it's bony tissue onto soft tissue. And that naturally then causes dissociation of the tissue bonds. So it actually slowly but surely disrupts those tissue bonds until they can't hold themselves up anymore. The architecture or the structure of the cornea can't be held up anymore, and it slowly starts collapsing. So we are seeing more and more of this nowadays, and especially in the Southern Cape, because we're seeing a large influx of people down to the garden route. And of course, with that comes the younger generation. So people may or may not know that they've got keratoconus, and it's often first diagnosed when they come to an ophthalmologist for a general eye exam saying that I'm not seeing well. That's why we've got to have the diagnostic equipment to be able to pick this up, and if there is progression of the disease, to then treat that.
Okay, and then there's a new term that we're going to discuss as well today, cross-linking. What is cross-linking?
Yeah. Okay. So first one needs to, as I said in my last sentence there, determine whether there is progression of this disease or not. And if there is progression, it's then about halting the disease progression. It's not about necessarily halting it in a once-off process. We've got to stage it. We've got to see what stage of the disease is this keratoconus, what is the age of the patient, and what is going to be the best approach to trying to halt the progression of this disease. So there's a number of other treatment on keratoconus, but if you think about the process of the bonds breaking down of the cornea in keratoconus, cross-linking is a procedure which tries to then stabilize these bonds so that they cannot change the corneal shape anymore, so that they can't be broken down any further. So it's important to also realize, because people think cross-linking is going to cure my keratoconus, it's going to stabilize my cornea and make my vision better. It's not going to do that at all. Cross-linking is simply about stabilizing the bonds that are breaking down. And in certain cases, because of the effects of cross-linking, we can get some flattening of the cornea and actually a small improvement in vision, but it's certainly not a procedure that is done to try and improve the quality of your vision. It's about stabilizing disease. So what is cross-linking? Cross-linking is a method where we expose the cornea to riboflavin solution, and a combination of that and oxygen and ultraviolet light. Now, it undergoes a photochemical reaction which causes stiffening of the bonds within the cornea. Interestingly, we undergo a natural cross-linking phenomenon as we get older through life. So each decade that we go through, because of our exposure to ultraviolet in the sun, we naturally get our corneas cross-linked. So by the time we're 40, 50, 60, we've actually got pretty stiff corneas because of the natural ultraviolet that we're exposed to. But as a teenager, as a child, or as a young 20-year-old, those bonds are not stiff enough. And if you've got this genetic disease that is progressive, so it's about making sure that it is progressive first, and we only can do that by looking at consecutive scans, 3 monthly, 4 monthly, depending on how rapidly we think this may be progressing. Then we need to do a procedure called cross-linking to halt the progression of the disease. And once the disease is halted, we can then look at it and say, okay, what are our options?
This is very interesting. Okay. Now, what are the types of cross-linking, Dr. Joseph?
So broadly, there's two types of cross-linking. One is called epithelium-on cross-linking, and the other is called epithelium-off cross-linking. Now, the general procedure that's done the most is the epithelium-off cross-linking. The epithelium, if we go back to our Anatomy 101 days on our first or second episode, it's the top 50,000th of a millimeter, 50 microns of tissue on the top layer of the cornea. So with epithelium-off, that's exactly what it is. We actually manually scrape off or debride that epithelium, soak the cornea in this riboflavin, then expose it to ultraviolet, which stiffens the bonds. It's a very uncomfortable process to recover from. It's a long visual recovery and can be fraught with a lot of difficulties in the healing process. So one needs to watch these patients very, very carefully. The epithelium-on process has been thought for many years not to work as effectively as the epithelium-off process. But there are very specific techniques that one can apply with epithelium-on cross-linking. So we're preserving the epithelium, we're not taking it off. So the recovery process tends to be a lot quicker and far less discomfort. There is literature to say that epithelium-on cross-linking doesn't last, that it needs to be repeated or eventually needs to be converted to an epithelium-off cross-linking. And there are cases in which that needs to be done. But by and large, if it's done in a certain fashion, a certain manner, then we can cross-link your cornea by keeping your epithelium intact. So broadly, those are the two groups, epithelium-on and epithelium-off. And where I did my fellowship training, we did epithelium-on. It's a lot more comfortable, as I said, in the recovery process, less discomfort, less pain, and less propensity for infections and inflammatory response afterwards. And it can be repeated. That's the other thing. If we find that there is still progression, we can still repeat epithelium-on. We can do an epithelium-off. It just depends on what we feel is defined as progression at the follow-up visits.
This has been very, very interesting, Dr. Joseph. Thank you so much. Tell us, how do we get in touch with you?
No, big pleasure, Jan. Thanks for having me again. We're at the Advanced Health Center in Knysna at the Vision for Life Clinic. Our office number is 044-150-0085, where Mariska can answer a couple of your questions. And you're welcome to write us an email as well to info@drdylanjoseph.com. It's drddylanjoseph.com. We have a number of social media pages, including Instagram and Facebook, and a YouTube page as well, where we've got a lot of this information, and a lot of our podcasts are broadcast onto that channel as well. So you're welcome to go and take a listen to them there. And if you've got any questions, please feel free to get in touch with us.
Fantastic. Dr. Joseph, thank you so much. Until next week.
Big pleasure, Jan. Have a great week.